First presenter, Dr. Salil Kumar Mandal. And he'll be presenting a video on From Staring to the Elegant Look.
Respected judges and my colleagues here, this is a surgical treatment of Krebs orbitopathy. Just watch it. Sound. But it is injurious to health. Follow your hero, but not to follow the art of smoking. Female smokers are very dangerous for the development of eyelid retraction. So stop smoking, otherwise you may have a problem. What problem? Female with known thyroid disease having smoking is more prone to develop Krebs orbitopathy, and lid retraction is the commonest clinical feature. How you treat this patient? How you elongate the lid? It's a special material applicable. What material to be used? It is a Banks sclera fascia lata, having some disadvantage fascia lata. What is the ideal material for it? Filamentous knitted polyester fabric used in cardiovascular surgery for heart stability, arterial reconstruction, and tendon repair. Filamentous knitted polyester fabric can be used in Krebs orbitopathy for elongation of the lid. All the case done in the study in the inactive phase of the Randall's curve plotting. New hope, new innovation, lid crease incision made. Tarsal plate and orbital septum is exposed. Central part of the LPS muscle detached from the superior border of the tarsal plate and retracted upwards to create a semilunar space. Novel filamentous knitted polyester fabric inserted into the created space as a spacer material. This is a filamentous knitted polyester fabric which is used upper border of the tarsal plate suture with a spacer material by a interrupted suture. So this spacer material prevent the reattachment of the redundant LPS muscle and desired length is cut. This is the first patient in our study operated. After that, we made a protocol on a spacer material. Our protocol is induce a moderate doses. To achieve a moderate doses, length measured from the surgical limbus is 5 mm and scale show if it is suppose 4 mm plus extra 3 mm. The total length of the semilunar is horizontal 26 mm and the vertical or central wide is 12 to 14 mm. The object is a moderate doses induction. Interrupted suture is made to close the own margin. Spacer material is create a space between the upper border of the tarsal plate and redundant part of the LPS muscle to prevent the reattachment of the LPS muscle. Almost the upper border retraction correction. Approach to the lower lid through conjunctival approach. Incision made along the lower border of the tarsal plate. Inferior retractor is cut from the inferior border of the tarsal plate to create a semilunar space. When the conjunctiva is cut, after that the next material is inferior retractor. When the inferior retractor is cut from the inferior border of the tarsal plate and create a semilunar space, and the cut margin of the retractor is thrown back, create a semilunar space. Inferior retractor shortening is the main cause of retraction of the lower lid, and shortening or fibrosis of the LPS and Mueller's muscle may cause retraction of the upper eyelid. These two retraction upper and lower lid made by the LPS or inferior retractor or Mullers muscles. These are elongation with the help of spacer material. The novel filamentous knitted polyester fabric inserted into the central space as a spacer material between inferior border of the dorsal plate and the redundant cut margin of the inferior retractor. Here the superior border of the spacer material joined to the inferior border of the dorsal plate. Interrupted suture made in spacer material and a dorsal plate margin for fixation of this spacer material. One of the border is sutured and another border is free, which is sandwiched between the conjunctiva and the other structure of the lid. So desired length of the spacer material is cut. So in case of lower lid retraction, the measurement of the spacer material is 7 mm by 20 mm, 7 mm central width and 20 mm horizontal length. After that, conjunctiva is mobilized very carefully. This conjunctiva is very precise. Conjunctiva deposited over spacer material and fixed to the lower border of the dorsal plate with a 5-0 polygalactine suture. Conjunctiva sutured to the lower border of the dorsal plate with a 5-0 polygalactine suture covered the spacer material. Interrupted suture made here. In all the cases, interrupted suture preference is much better, otherwise it may cause loosening. Then conjunctiva is well sutured. Upward traction suture made kept for 4 days. This upward traction suture maintains the semilunar space between the lower border of the dorsal plate and redundant part of the inferior retractor. These are the beneficiary of the patient in our study. Upper lower lid retraction correction by novel filamentous knitted polyester fabric in Graves orbitopathy. This is the pre-op and post-op picture of the beneficiaries and our series of patients. Thanks for your kind attention.
Thank you, Dr. Mandal. I think it was really a good video. I would like to know the polyester, the spacer that you're using, is it novel? Who has developed it and what has been used beforehand, before this?
Actually, this is used in cardiothoracic surgery, but it has never been used in ophthalmology. So, suppose the patient have a ventricular septal defect or arterial aneurysm, they wrap this with this material for stability of the heart or stability of the artery. We are the first time use this spacer material for the lid lengthening procedure in thyroid ophthalmopathy.
Your results are indeed good
Yes.
for both the upper and the lower lid.
Both.
So are you analyzing your results and putting it across? Have you seen the statistics?
Yes, almost our study is over. This is a video presentation. We have a free paper presentation here. The study is almost, we are success all the cases, and we are achieving at the normal lid level.
Okay.
The most important is the timing
So
of.
how have you made the table by which you guide yourself how much spacer to be inserted for what level of correction? Is that a nomogram or something for that?
Yes, we have a formula.
You showed it, but how did you come to the conclusion that this is the formula and we should be applying this much?
Because we are trying for the last 3 years for the we doing research on Graves orbitopathy, which is the correct procedure or formula that applicable, and the result. That is why we made the formula. The formula is we induce a moderate ptosis. That is for the length of the surgical limbus is 5 millimeter, plus scleral show. Amount of scleral show add this plus 3. Lee's a scientist who developed this formula. His formula is 2 into scleral show plus 2. Our formula is 5 plus 2 scleral show plus 3.
Any
The result
complications?
is
Complications that you have seen with this spacer?
complication is there. This material, it may causes avascular zone. That is why we created a hole. And
What does it cause?
avascular zone,
Okay.
because it's inside the heart. And we found there is a healing problem at first. But what is the cause? We don't understand. Then we create modification of that implant as a central hole, 3-4 hole. The blood flow from the posterior lamina to anterior lamina, and it is a better healing. At first time, they have their own gapping. But there is no infection. What is the cause? Then I thought this material may cause avascular zone, because it is used in a cardiothoracic surgery, vascular surgery, repair of the ventricular septal defect. This is the first time used in ophthalmology. I never been used first time. So after that, making a multiple hole, our success is highest, and own gapping is not there.
Yes. So congratulations for a successful
Thank you.
procedure, and we hope that it is published for the benefit of others.
Yes,
who are doing
published within now. It is study is complete. Our paper is this is a thesis of one of the resident. He submitted. Now we publish.
Okay. So also I would like to suggest whenever you do a video presentation of a novel technique, if you include your results in terms of quantitative numbers and any complications that you see, it will make it complete. Thank you. So I don't have the list of who all are here. So we have in this list, Powerlifting the Sunken Eye by Dr. Manjula Jaikumar. Is she here? Yes.
None of the producers have any financial interest in any of the products or procedures mentioned or shown in this film. No copyright infringement is there in the music used in the video.
Powerlifting the Sunken Eye. This is an epic scene. When a mighty ship went under the depths of the ocean, nothing could be done. When there is a sunken eyeball, can anything be done? Let's see what happens. Causes for sunken eyeball: hydrocephalus and sunset sign. Raised intracranial pressure causes downward pressure on the eyeballs, resulting in downward displacement of both eyes, which is the sunset sign. Floor fracture of the orbit with entrapment of fat and inferior rectus muscle causes sunken eyeball. Monoocular elevation deficit with inferior rectus contracture seen in congenital ptosis is another cause of sunken eye. Pathological myopia with hypertropia esotropic complex results in heavy eye syndrome and sunken eyes. Third nerve palsy results in large exotropia combined with hypertropia, resulting in sunken eyes in eccentric position. Now, let's see our story. A 53-year-old gentleman from Dubai who sustained a road traffic accident and was in ICU care in a comatose state for 45 days. When he opened his eyes, this was his state: complete ptosis of the left eyelid with absence of extraocular movements. The eye was fixed in a down and out position, a state of sunken eye in eccentric position. So, we had to set his eyes right. We embarked on a full tendon medial transposition of lateral rectus muscle superiorly to the medial rectus to correct the exotropia and hypotropia. This is an animation depicting the surgical procedure. The lateral rectus muscle is disinserted and transposed superiorly underneath the superior oblique and superior rectus muscle to the upper border of the medial rectus insertion. Let's see the surgical procedure. A limbal flap is created temporarily. The lateral rectus muscle is hooked. 3-point fixation of the lateral rectus muscle is performed and the muscle is disinserted at the insertion. The superior rectus muscle is hooked and found to be tight. Therefore, we hooked the inferior rectus muscle and did 3-point fixation and disinserted the muscle to provide adequate maneuverability. Again, we hook the superior rectus nerve and tag it with non-absorbable suture. We hook the superior oblique muscle and perform posterior tenectomy of the superior oblique muscle. This allows easy passage of the full tendon lateral rectus muscle beneath the superior rectus and superior oblique muscle. Now, we bring the lateral rectus muscle to the upper border of the medial rectus and transpose it superiorly under adjustable sutures. The inferior rectus was reattached to its insertion. Meticulous conjunctival closure was done. On the first postoperative day, conjunctival chemosis was present, but his left eye had shifted upwards. On 10th postoperative day, there was a good alignment with no sunken eye. Now let's look at all the surgical strategies for third nerve palsy. Split LR transposition to MR. In this method, the lateral rectus muscle is split into halves and inserted into upper and lower border of the medial rectus respectively. This is done for large exotropia without significant vertical deviation. Preoperative and postoperative photographs of a patient with split LR transposition to MR. When there is aberrant regeneration in third nerve palsy, recession of the lateral recti and resection of the medial recti in one or both eyes can be done to provide alignment and elevation of the ptotic lid. In this animation, recession or weakening of a rectus muscle is demonstrated. In this animation, resection or strengthening of recti muscle is demonstrated. Preoperative and postoperative photographs of a patient with apparent regeneration of third nerve in right eye is shown. Large exotropia with lateral rectus contracture, periosteal fixation can be performed. Preoperative and postoperative photographs of a patient who underwent periosteal fixation in the left eye. Here is a look at literature review. Journal of the American Association for Pediatric Ophthalmology and Strabismus has an excellent article on split lateral rectus transposition. Supramaximal R&R has been tried in third nerve palsy with mixed results. Periosteal fixation has been widely reported in several articles. This procedure of single lateral rectus full tendon transposition has been published in British Journal of Ophthalmology and Australian New Zealand Journal of Ophthalmology. There is a complete change in the patient's world of view. We have power lifted his sunken eyes and changed his perspective of vision. We have reconstructed his topsy-turvy world. It is humongous, just like reconstructing a sunken ship back to its glory. Thank you.
Thank you, Dr. Manjula, for that excellent video.
Thank you, ma'am.
I wanted to ask, after how much time of the trauma did the patient undergo this surgery, and what were the preoperative measurements? If you can
It's almost a year. Okay, so this is an ideal time because we are giving some time for some recovery also to happen. We have done a CT scan of the orbit as well as an MRI of the brain in orbit. CT scan, there was not any fracture because, there's such a large sinking of the eyeball. We wanted to rule out whether there is an orbital fracture first. And of course, MRI in third nerve palsies is very, you don't see any particular thing except for mild thinning of the third nerve. And after a year, we undertook this surgery, had a ptosis, but he had a fairly good vision. The very reason we have taken this patient for surgery is his best corrected or his uncorrected visual acuity itself was 6/18. He didn't have a very significant traumatic optic neuropathy. Since there is a good vision, we wanted to give him, perceive that vision. And that is why this particular surgery was done. And this is fairly a newer surgery. What usually people do is the split LR transposition to upper and lower halves of the medial rectus. But this particular one full tendon transposition either superiorly or inferiorly actually gives mixed results. If you can see that paper publication by Dr. Rohit Saxena, there are 5 case series. And this was a very fairly large angle of hypotropia. It was almost 50 PD and the XT was 60 to 65. Such a huge hypotropia, we have completely lifted the eyeball up. So it was a very good result actually. Even I have tried in a few other patients, but this particular patient had a very good result. Smaller angles of hypotropia, it corrects very well. For a large angle, I was just wondering. And we haven't done anything on the inferior rectus. We released it and reattached to the same position.
You could have done some recession of the IR also.
No. We just
you could have done because you had just
No. I wanted to see how much this superior thing gives
so
completely.
titration is still going on.
Yeah, I wanted to see one surgery how much result it gave.
Congratulations. Thank you.
Thank you very much.
So we call for the next author, Dr. Manavi Devakrishna Sindhul. Is she there? Yeah. She'll be talking on breaking barriers, telescreening revolutionizing ROP care.
Good afternoon.
The world's most populous country, with over 1.4 billion people, faces various unique healthcare challenges. Among these challenges is the high rate of preterm births, the highest globally. The widespread implementation of specialized newborn care units at both district and sub-district levels has revolutionized treatment accessibility. Equipped with advanced life support and comprehensive care, these units have significantly improved the survival of premature babies, reaching even the most remote corners of the country. All the babies that could be saved are being saved. All is well, except it isn't. With these advancements came another challenge: retinopathy of prematurity, or ROP. This potentially blinding disease can lead to severe visual impairment if not detected and treated in time. Early and timely screening is essential. Breaking barriers Telescreening revolutionizing ROP care. Previously, only a trained ophthalmologist could perform ROP screening. But with the surge of telemedicine, various projects for telescreening in ROP have been successfully initiated across India. Notable among these are the Kid Drop project, the Vitalla ROP project, and the Rope SOS project. We at Aravind Eye Hospital, Pondicherry have also established a telescreening system. Over the past 4 years, we have screened 1,285 new and 951 review babies, diagnosing ROP in 248 of them, of which 79 babies required treatment, 51 with anti-VEGF and 28 with laser. Encouraged by the success of ROP telescreening, our next goal was to expand the service to more areas. We met few healthcare providers and called up few others, but all were reluctant, citing some or the other issue. The first barrier of lack of local support and funding slowed our pace. But then came a pivotal moment in our efforts.
Hello, I'm Mr. Param Sivam. I have been fortunate enough to sponsor some of your cataract camps in Kollidam area. I've heard your team is doing great work in checking eyes of the babies, and that doing so can prevent possible blindness. Can you start it in our area too? I will take care of the transport and other charges.
This was our first break. Prior to initiation of screening, we met with Dr. Narendran, a medical officer at the Kollidam Health Facility. This is where we met our second unlikely barrier. Despite being aware of the need for ROP screening, he was skeptical about the process and raised many doubts. We methodically addressed his concerns. We demonstrated how the RedCam device is used for telescreening. The transportation, setup, and imaging by trained technicians to capture and upload images for remote review was shown to him. Our consultant demonstrated the iTelligence software used for remote reporting. We assured him that any baby requiring treatment would be referred to the base hospital for confirmation. Detailed videos on injection procedures and laser treatments were shown to alleviate medico-legal concerns. By presenting data from our past work, we estimated the number of babies in his area that might have ROP. The significant number highlighted the urgent need for screening, convincing Dr. Narendran to support our initiative, thus overcoming our second barrier. We were now set to implement the telescreening program. On the screening day, we faced our third barrier, the lack of awareness of ROP screening criteria amongst the SNCU staff. All babies born that week were referred for screening. We had to meticulously review records to identify eligible babies, causing delays. Back at the base hospital, we developed an information poster and circulated a protocol among pediatricians in Kollidam area, specifying inclusion criteria for screening. 1. Gestational age of 34 weeks or less. 2. Birth weight of 2000 grams or less. Screening was to be done before discharge from SNCU, NICU, or by 30 days of life, whichever is sooner. A recurring date for screening was decided. On the next telescreening date, the process went smoothly. Mr. Paramasivam was impressed and expressed his gratitude for our work. Together we can, by breaking these everyday barriers and revolutionizing ROP screening, we are taking small steps towards preventing blindness while helping these children take strides towards brighter future.
Thank you so much for the beautiful video. And I just wanted to know, so how many districts are you covering through this?
Primarily, other than the state of Pondicherry, we are covering Kadalur and Chidambaram currently, and are looking at Nagapattinam, a third district.
Okay. So is it a foolproof method that all the kids who are being born at these, because you are, I think, recruiting only one hospital in one district. Is that
We are going to the government hospital in Kadalur, the government hospital in Chidambaram, and looking to the government hospital at Nagapattinam.
But there might be other government hospitals.
Yes, there are.
So it's still not a foolproof.
No, it's not foolproof, but we are trying to reach out to as many as we can. Yeah. We also get babies coming to the base hospital from these places. So it's usually the babies born in the private hospitals, they tend to be from a more affluent background and could probably get transported. But the government set up babies, you know, no matter how much we explain, it's difficult to get them. So that's where we are primarily having.
So lasers and the injections and the surgeries, if required, they are done at your Arvind Eye Hospital?
For lasers and injections, if the baby can come to us, they come to us. If they can't, we go there and do it. Right. So that for the screening, our technicians go and we remotely screen. Even before that, if we have a doubtful baby where we feel this baby is likely to require treatment, then one of the consultants with the OT staff, with our full bin with the Avastin injection and everything, we go there. We screen and if required, inject and come.
So I think it's really commendable the work you are doing in the peripheral areas and for the rural population. But we would really like to see that one day it becomes foolproof and that can be, you know, replicated in the whole of the country. And because ROP is, of course, on the rise.
Yes,
as the prematurity is increasing. So we really want this. Ma'am, you are, you know, mentoring this, so maybe you can come up with more ideas to make it.
Hopefully it should go. Thank you.
Thank you so much.
Thank
Wonderful
you so much.
video. Yeah.
Ma'am, I'll be moving to the other session where I have a presentation. Thank you so much.
Thank you.
So we would like to call the next speaker, Dr. Samrat Chatterjee, to present his video on celebrations to nightmares. Dr. Samrat, please.
Can I have the video?
Accidents come without a warning and can mar any happy occasion, turning celebrations into nightmares, causing pain and darkness in the flash of a moment. Each day, hundreds of eyes are damaged from ocular trauma. 1.6 million eyes go blind each year, 2.3 million people fall into low vision, and there are almost 19.3 million who are blind or with low vision in one eye. Each generation celebrates in their own style. Today's Gen Z does it with party poppers and party foams. Party poppers. The name is so deceptive, something that will only pop. But sometimes pops with a vengeance. Most party poppers are very low-grade explosives. This mini arm-strong mixture is packed in a compressed canister at the bottom, which on twisting, starts the chemical reaction. The reaction releases sulfur dioxide gas that causes the explosion. The confetti are small pieces of paper, but sometimes contain glitters and bits of plastic. Ocular injury from a party popper results from the shock wave of the jet of air, and also from the mechanical trauma by the flying confetti. This 9-year-old girl had gone to her classmate's birthday party. When she got injured by a party popper, she complained of severe pain, redness, watering and reduced vision in the right eye. Her visual acuity was hand movements. The eyelids were edematous. There was conjunctival chemosis, congestion, subconjunctival hemorrhage, corneal abrasion and edema. A severe anterior chamber reaction and hyphemia was present. Intraocular pressure was 10 mm of mercury. The vitreous cavity on B scan was normal and the retina was attached. After treatment with topical antibiotics, corticosteroids, and cycloplegics, the vision improved to 20/20, but there was angle recession in 3 quadrants. So, this child carries a lifelong risk of angle recession glaucoma. Another 12-year-old girl presented 8 months after she was injured by a party popper at her cousin's birthday party. Her vision in the affected left eye was 20/125, which was not improving. There were no abnormalities in the anterior segment, but fundus examination revealed a choroidal scar in the subfoveal area and a macular hole. So, a lifelong burden of vision impairment, only from going to a birthday party. Another item used in parties are party foams. These chemicals mix and when released under pressure through a nozzle, form foam. Party foams are alkalis. Due to the chemical composition, they are sticky and adhere to the surface epithelium. On contact with skin, they cause skin irritation. Imagine what they will do to the ocular surface. A 25-year-old male presented with pain, redness, watering, intense blepharospasm, and reduced vision following entry of party foam in the left eye. His vision was 20/125. There was eyelid edema and conjunctival congestion. There was diffuse superficial punctate keratitis, fine and coarse, affecting both the conjunctiva and cornea, including the pupillary area. These resolved in 1 week after treatment with topical antibiotic, corticosteroids, cycloplegic and preservative-free lubricants. Another patient came from his wedding with a large corneal abrasion when party foam had entered his right eye. We are not the only center to encounter such examples of trauma. There are multiple reports in literature which have described serious ocular injuries from these items used in celebrations. Studies related to injuries with party poppers report corneal abrasions, hyphema, iridodialysis, traumatic cataract, lens subluxation, secondary glaucoma, angle recession, vitreous hemorrhage, retinal edema, macular hole, and choroidal rupture. Studies related to party foams or artificial snow have reported ocular surface damage similar to alkali injuries. Some of these injuries needed complex ocular surgeries. Injuries from party poppers and party foams are underreported. There is a low awareness level about the dangers of these in the community or among health professionals. Because, who can get injured from foam or an item that only pops? As you are watching this video, incidents of these injuries are occurring across the globe. There is an existent partial ban on party poppers by Government of India. Is the ban implemented? Sadly, the answer is no.
सब चलता है.
Generally, foam appears to be harmless, and party poppers are not placed in similar categories as crackers. Therefore, the general perception is that these are safe.
It is time to take a stand, and you as a responsible healthcare professional need to take the stand.
The All India Ophthalmological Society needs to take the stand
To advocate a ban on these items
and create awareness in the community regarding the danger of these items.
So, let that initiative begin from here.
Thank you so much for the awareness campaign that you've made.
Thank you.
Indeed, I have not seen any injury with the party poppers. How about you, Dr. Asta?
So after these few cases, we had two more this thing. Okay. Children and one child and one adult with this party popper injuries. So it's not very common, but this is something happening. Use of it is very common. I'm sure we have all used it.
So have you thought of any guidelines that you would like AIOS to take forward, the Government of India to take? So anything that you have sought or thought about?
So the guidelines are there.
There is written on the party popper that this can harm the ocular surface and should be avoided.
Yeah. So right now, actually, I was just before this, I was in another meeting there, and it seems for crackers, Professor Natarajan has filed a PIL for crackers. Why I'm saying the crackers is to give you the context to party poppers. So there's no PIL existing for, there's no rules, there are rules, regulations, they are not implemented for crackers. Last Diwali, we conducted a survey where more than 200 ophthalmologists said that they see serious injuries. And just today, somebody informed that Professor Natarajan has filed a PIL in Supreme Court for ban on crackers. We all know about the deleterious effects of crackers. Each Diwali, we see that. Party poppers are categorized as something in crackers according to that government notification. There's no implementation. that I use that term, na, sab chalta hai, so everybody in Central and North India would know, sab chalta hai. So that implementation is not there. So the implementation will only come when we create an awareness. We have few cases now, but probably, the gathering body of evidence would probably, motivate. It has not motivated AIOS to make a stand on crackers for so many centuries.
So maybe you at your level, so these things may take time.
It'll take
because
time.
Firecrackers, as yet, we don't have any any legal this thing. But for at least what you can do is you can write editorials for public awareness, these things, so that public is aware, and maybe you can, take it forward through AIOS that the companies should write on the packet itself, like cigarette packets, that it can be harmful to the eyes.
Yeah, so because this was in video, so I have not sent it as a publication, as a case report. So the case report and the case series is there. So that is going to be the second step. But because it got accepted as a video, I couldn't use these cases for that. So that is going to be the next step. And if IGO deems it to be published, then probably they would also invite a commentary on this from trauma professionals, and then probably it should carry forward.
You should think of newspapers.
Yeah, newspapers you have already written in the local level.
Because
we have written.
Because it's still not very popular. Like firecrackers, rural, urban, everyone is using. Party poppers is probably more. It's not, but with social media, I'm sure that every kid in his or her birthday party in 1 or 2 years, it will become a popular trend.
So these are all videos that I took from some of the social media posts from our hospital people, and I'm sure tomorrow there's going to be this gala dinner, there will be a banquet, there will be some fashion shows, and trust me, remember me if there is no party popper use. Thank you. Thank you for the comments.
The good thing is that you didn't have any sight-threatening complications. So all the cases in your series, there were no
angle recession, choroidal detachment, choroidal rupture, in reports, cataract surgery. So these are serious consequences.
Yeah, but like the cases that you showed, most were managed, like the ocular surface ones were managed beautifully.
It is managed.
They did well, but yes, of course,
So we have not had an eye with thysis bulbi because of party popper, or we have not had limbal stem cell deficiency with party popper. But probably one day we are going to see that, or probably somebody has seen it.
Yeah. Thank you so much.
Thank you.
Yeah. We would like to invite Dr. Purva Kher, if she's here. Is she here? I don't think she's here. Next, Dr. Jyoti Matalia. So she'll be presenting on eye-to-eye tackling squint surgery with patient in Fowler's position. Can I have the final list of the presenters who are here? You can bring it up here. Ma'am, you can start.
The life of every ophthalmologist revolves around various instruments in the OPD as well as in the OT. Most surgeons operate in the standing posture during general surgeries, endoscopic surgeries, except for neurosurgeons and ophthalmologists who fortunately or unfortunately have a surgeon's chair. Different surgical positions are used depending on body part involved. For ocular surgeries, it is the supine position. The correction of this patient's right eye, 55 prism diopter esotropia and 30 prism diopter hypertropia, was planned under local anesthesia with monitored anesthesia care, but in a staged manner, since she was suffering from Eisenmenger syndrome, a condition where she cannot be allowed to be in supine position for a long duration. Since we planned a stage surgery, we decided to operate the right eye in the first sitting and the left eye in the second sitting. During the first stage, wherein the supine position lasted for 60 minutes, inclusive of administration of the peribulbar anesthesia, she developed pulmonary edema, which warranted abandoning the procedure and shifting her to a cardiac unit. Eisenmenger syndrome is a congenital ventricular septal defect which, if not repaired, leads to pulmonary hypertension. In the first stage, we performed MR recession in the right eye of 6.5 mm and superior oblique tenotomy. The patient had a residual 25 PD esotropia and 20 PD hypotropia. So how to perform the second stage procedure for the residual esotropia when your patient cannot lie down in supine position was then the question. Can we operate in sitting position? Operating eyes at eye level, squint surgery in Fowler position. These are the low, high and standard Fowler position. We use the 60 degree standard Fowler position by inclining this adjustable bed. Local anesthetic agent was administered in supine position and then shifted in the operating area in the Fowler's position. The OT assistant preparing a sterile zone for the surgery is what you can see. Whether supine or Fowler position, maintaining working distance to avoid musculoskeletal disorders is the key. An additional drain bag was attached inferiorly to drain any fluid during the procedure and prevent soiling of the surgeon and his assistant. Notice the surgeon operating at almost her eye level. You have to ensure that there is a good support to their elbow and wrist joint. Note that during all steps, proper surgical ergonomics is followed. Although it appears to be easy, maintaining the same posture for very long duration is indeed difficult. In the second stage, since the patient had a residual 25 PD esotropia and 20 PD hypotropia, we performed MR recession of 6.5 mm in the left eye and SR recession of 6 mm. This is the first case of strabismus surgery performed in Fowler position. This procedure was accomplished comfortably without any complication because of the team effort involving the anesthetist, the OT staff and the surgeon. Use of a binocular loop gives you the freedom of operating in sitting or standing position along with the freedom of rotation. In this photograph, you can make out that the patient is orthotropic and happy. All of us therefore should learn to use the binocular loop for these advantages, not only for our own but also for our patient's benefit. So remember, the goal of the treatment is not only to align the two eyes but to prevent not only any ocular complication but also any systemic complications and ensure that the patient is happy. Thank you.
Thank you, Dr. Jyoti. So what is the magnification that you can achieve with the binocular loop?
So the loop, I normally use the loop always to do my squint surgery. It's about 3.2 is the magnification. So idea about squint is that we don't need to have a big magnification like in microscope. In that we have minimum 4 times, which is sufficient. The advantage is you can move around and then you can focus. So the magnification wise is 3.2. Now this patient actually had a major systemic condition and we have told her that you didn't want. But they are having a very short life and her only goal was to look beautiful. So what we could do least is make her happy. And that's the plan. Why, in spite of the first time we had to shift her, it was a major calamity. She's like, no, you do anything but give me my eyes straight. That was her only wish. Yeah. This is a patient come from Bangladesh. Yeah.
So any recommendation that you would like to give if the patient comes next for the cataract surgery now? How would you plan to do that?
I'm just hoping she's young, she'll not land up, but yes, it's not very easy.
So for the take-home message, all of us don't do squint surgeries, right?
Yes, right.
So if a situation like this turns up for any of us, a patient with a systemic problem where he or she can't lie supine, what do you think could be possible for those patients with a normal microscope?
No, I think cataract surgery is not difficult because, faster surgery can be done in about 10 minutes. You could have somebody mad. So her issue was we could not make her change the position for more than 40 minutes. That was allowed. But in cataract, you can finish off in 10 minutes. So if you make her supine, so what mistake we did first time is we got her, we put her down, we give anesthesia, we put her under. So we didn't realize that sleeping time got included. But if you can give her block and all sitting, and just when you're doing, or even under topical, and then take her under cataract just for 10 minutes, it's fine. So sleeping up to half an hour is allowed that way.
So maybe Trendelenburg positions can be, tried
yes,
for
yes,
this,
right,
where
right.
the reverse Trendelenburg position where, head is up above the body, and the legs are, that can be done, I
Oh
feel.
no, the chest has to be above. That is what was important for this
the legs
patient.
can be made to lie low, and the head could
Can be done,
yeah,
right, right,
yeah,
right.
little
Okay.
bit, yeah. Thank you.
Yeah.
Any questions?
And you still had like the anesthetist around, and for any kind of emergencies.
Yes,
you would
yes.
Still, I think that is an important.
Yes, that's very important.
point.
Yeah, fine. Yeah.
Thank you.
Thank you.
Thank you. So, can we have the next presenter, Dr. Arvind Krishna, to present his video on pediatric vision and refraction tips and tricks? Dr. Arvind.
Vision and refraction are vital to any ophthalmic examination, especially in children. But estimating vision and refraction in young children is challenging. Seeing a child in the clinic for a vision and refraction exam puts both the ophthalmologist and the child in a fix. In this video, we bring you the right methods of easy vision assessment and simple tips and tricks for a seamless vision assessment in children. Here we present vision testing with OKN drum in infants. Optokinetic nystagmus is elicited by moving a large piece of paper covered with black and white square patterns in front of the child's face at a distance of 40 cm. The number of saccades in response to left side stimulation is compared with that of right side stimulation. Optokinetic nystagmus test is normal when the response to left and right side stimulation is symmetrical, whereas an asymmetrical response will indicate an abnormal result. This test can be done for children of up to 3 to 6 months of corrected age. In slightly older children or toddlers, forced preferential looking tests like teller acuity cards or tag cards may be used. Two stimuli are shown: a grating composed of black and white stripes and a grey screen of equal space with an average luminance. An observer, unaware of the location of the pattern stimuli, is positioned behind a peephole located centrally between the grating and the homogeneous field. The observer monitors the direction of the child's eyes and head during stimulus presentation. Acuity is estimated by determining the smallest striped width to which the infant will show differential fixation for the grating as opposed to the homogeneous field. Here is a tip. The observer must look through the peephole. Holding the card in front of the child with the observer looking above the card might distract the child as well as induce bias in the observer. Do not provide audio clues to the child by tapping on the card, as this might also mask or confuse the response. Tag cards are usually flipped and held in horizontal orientation only. Here is another tip. In cases of horizontal nystagmus, inability to generate neck or eye movements as in cerebral palsy or oculomotor apraxias, tag cards can be assessed in vertical orientation. The child will look up or down in response, and visual acuity can be reliably assessed. The advantage of tag is that visual acuity can be checked at different distances. LIA paddles. LIA paddles are another form of resolution acuity testing which will measure acuity as cycles per minute. They contain a control paddle and a test paddle with gratings. This is typically tested at 30 cm and can be oriented laterally and vertically to assess visual acuity. In special children, when there is no response to either paddle, slight movement of the paddles may initiate a response. Dynamic motion on the stimulus will initiate a visual response in special children. Matching cards. Recognition visual acuity can be assessed by matching cards. Children with special needs, developmental delay, amblyopia or crowding phenomenon may not respond and may get confused when presented with the entire vision chart with multiple lines and optotypes. This is due to crowding phenomenon, where they have difficulty in processing multiple visual stimuli. In such cases, allowing them to match single octotypes at distance will give the precise visual acuity and potential of the eye. Refraction. Retinoscopy is an art by itself, and for children this art becomes stressful and tedious. Children refuse to wear trial frames as they are very heavy. Phoropters are scary. Free lens refraction is easy and children cooperate better. Retinoscopy can be performed by holding individual lenses in front of the child's eye. The child does not feel threatened by large frames in this process. In addition, using full aperture lenses can help in better retinoscopy because children may not fix well and may turn their heads while examining. Full aperture lenses, as opposed to mini aperture lenses, can give a wider field and easier access to retinoscopy in young children. Children with nystagmus, eccentric fixation and large head postures can also benefit from full aperture trial lenses. Dynamic retinoscopy. Accommodation assessment is done by MEM retinoscopy, wherein there is a card with letters attached to the retinoscope. This is a dynamic retinoscopy that is done with the patient reading a near print and accommodation is assessed. In children who do not read at near, dynamic retinoscopy can be done by assessing retinoscopy at distance fixation and at near fixation. A myopic shift will be noted at near. To encourage fixation to an accommodative target at near, a toy or sticker with fine details can be used on the retinoscope. This ensures good shift of fixation from distance to near, inducing accommodation which can then be measured. Over refraction. Children with high refractive errors, high plus or minus, who come with glasses for review need not be put through trial frames and loose lenses again. Refraction can be done over their existing spectacles to assess for change in refractive error. Here is a child with aphakia and nystagmus, unable to maintain central steady fixation. Over refraction with her own spectacle is hassle-free than a trial frame and mini aperture lens. The child also cooperates much better. Following these techniques will enable quicker and a more efficient clinical examination, thereby making life all the more simpler.
That's a beautiful educational video that you have created, and we would like to have the link if you have, so that we can share with our residents and optometrists.
Sure, ma'am.
It's because demonstrating and looking at these visuals, it will be easier for comprehension. So what is your target audience for this? Why have you created? What made you create this video?
What made us create was for children under 6 years, where you typically cannot use Snellen's chart or other standard techniques to assess vision. You need other methods such as the Lia paddles or Taylor acuity cards or OKN drums. But in tertiary centers, you have trained pediatric refractionists to do all this. But in primary or secondary centers, where you do not have anyone specifically trained in these techniques, they've only seen all these either in theoretically or in textbooks. So it's basically an educational tools for them to help them understand how exactly to use these devices. The government gives all these devices to them, but it's always just in a box. How do we take it? How do we use it? And how do we clinically make it significant is what
we would really like to have the video link with
Sure,
us.
ma'am.
Thank you so much.
Thank you so much.
Okay. So next is Dr. Chavi Gupta. Is she here? Okay. She'll be talking about Split the Oyster to Find the Pearl, with the co-author being Dr. Seema Das. We can just cross-check. Is Dr. Madhavi Ramanatha Pillai here? Okay. Dr. Abidur Rehman? Okay. Dr. Shruti RS? We don't have her here. And Dr. Shirali Gokhuru? Okay. You can start.
Hi, Dr. Chavi Gupta, on behalf of Dr. Shroff's Charity Eye Hospital, present to you Split the Oyster to Find the Pearl. A 31-year-old male came to us with complaint of protrusion of right eye for 7 months. The visual acuity was 6/6. On examination, right eye axial proptosis was noted and rest of the anterior segment examination was normal. No mass was palpable and a fundus showed a hyperemic disc in the right eye. Restriction of extraocular motility in upgaze and adduction was also seen. CT scan of the right eye axial scan showed well-demarcated non-enhancing homogeneous cyst with low density localized in the medial orbit. The coronal view showed the mass effect of the lesion. Diagnosis of orbital hydatid cyst was made after excluding other cystic lesions, and systemic evaluation revealed no lung, renal or brain cysts. The challenges faced at this stage were, firstly, excision of the cyst without rupturing it, and secondly, the location of the cyst, whether intraconal or intramuscular. We decided to go ahead with vertical lid split orbitotomy to approach the medial orbit under general anesthesia. A full thickness vertical transmarginal upper eyelid incision was given at medial and central 1/3 for gaining access using 15 number and lid plate. Care was taken to remain exactly perpendicular to lid margin. The incision was then extended to transact orbicularis muscle and tarsal plate superiorly to split levator aponeurosis, Muller's muscle and palpebral conjunctiva up to the apex of the fornix. Next, the incision was extended through the conjunctival fornix and directed inferiorly through the bulbar conjunctiva to superonasal limbus, and peritomy was continued. Then, these structures were secured with 6-0 vicryl and medial rectus was hooked and tagged and disinserted. The cyst was partially embedded within fibers of the medial rectus, which had to be split open to expose it completely. This allowed us to readily access into the intraconal space superiorly and inferomedially. The ectocyst dissection was done, and then daughter cysts were extracted carefully using lens spatula and right angled retractor. Here you can see gentle traction and minimal manipulation has been applied to remove the daughter cysts. Ectocyst was then carefully peeled off. Saline wash was done and medial rectus was reinserted with 6-0 vicryl sutures. The bulbar, palpebral and fornicial conjunctiva was closed with interrupted sutures. The lid margin was also closed with 6-0 vicryl sutures, followed by the repairing of the LPS by 6-0 vicryl, and then skin was closed with 6-0 silk sutures. The daughter cyst along with cyst wall was sent for histopathological examination. The patient's post-operative course was uneventful and he was discharged on first post-operative day with oral albendazole to decrease the risk of the relapse. The histopathology confirmed a kinococcal cyst with laminated membrane. The cosmetic outcome was achieved with improvement in proptosis and extraocular motility. Years after the surgery, the patient is doing well with no enophthalmos or proptosis as per conversation on teleconsult. This case highlights the need for early diagnosis of orbital hydatid cyst and its prompt surgical management. The clinician should always include diagnosis of hydatid cyst in the differential diagnosis of orbital mass, especially in an endemic country. My take-home message for this case is that intact removal of the orbital hydatid cyst can be challenging and thus requires good exposure and space for manipulation. Vertical lid split orbitotomy is a good approach for medial intraconal lesions. With gentle manipulation and pressure counter-pressure, cyst can be extracted without any collateral damage. And for such pathological treasures embedded deep in the orbit, sometimes diving into the deep sea of unknown is required to extract the pearls safely. Thank you.
Thank you, Dr. Chavi. It was a very, very elegant surgery, I would say. But since it's a competitive round here, so would you like to state whether something novel that you're presenting, or is it a routine procedure?
Yeah, orbital hydatid itself is a very rare condition. So one thing is that it needs to be diagnosed on time.
So just a suggestion, if you think that something is rare, you could have, in the beginning of the video only, you could have listed that this is the prevalence, it is very, very rare.
Yeah.
And the medial rectus involvement is also rare, or usually it involves medial rectus?
Yeah, it is usually involving the muscle if it is present, because the muscle tends to be more vascular.
So medial rectus is the most common?
No. More towards inferior rectus.
Yeah. So you should list these, so we also know that why this case is important.
Yeah.
And
the other part is obviously the vertical lid split orbitotomy, which might not have been an approach method for most of the surgeons. I think when you have to take out the cysts carefully and have space for manipulation, so that is why we took up this approach. Some people would adopt to transconjunctival or transcaruncular approach, but in that, if you do not have sufficient space, you might end up rupturing the cyst.
Does the size of the cyst also determine the approach? Like, was it a deciding factor since you had a double, two cysts, large cysts, that is why you opted for the vertical split?
Yes, because we were expecting multiple cysts and we wanted more area for manipulation, for safely extracting. Also, going by the CT scans, we couldn't really confirm whether it was intramuscular or in the extracorneal plane. So we had to be prepared for both that way.
Is there any role of intraorbital albendazole injection at the time of removal of the cyst? So is it
not that I know, like not in the review of literature. People have given a prophylactic dose before the surgery, but that is usually when there is a presentation with chemosis or there are exaggerated signs of inflammation. So prior to the surgery, you can give albendazole course and then take up the patient for surgery.
I feel just to be on the safer side, you could have done that. Thank you very much.
Thank you.
Yeah. So we next call upon Dr. Madhavi, and please the other presenters can sit according to their turns in front. So she'll be talking about path to evolution, transform into a MIGS surgeon with ease.
The impact of glaucoma is increasing in a rapid pace across the world. The question is, do we have enough glaucoma specialists to tackle this growing burden? The path to evolution has started. With the big boom of minimally invasive glaucoma surgery, these procedures are minimally traumatic, with easy learning curve, and has a good safety profile. They target the natural outflow pathway via Schlemm's canal. These procedures target sites like the suprachoroidal space, the trabecular meshwork, and the subconjunctival space. These array of procedures have added easy and more safer options to our armamentarium. Get ready to transform yourself into a MIGS surgeon. A well-prepared battle is half won. With adequate preparation and practice, the learning curve can be easily shortened. Preparation starts by performing gonioscopy in clinic, identification of landmarks, and intraoperative practice after routine phaco. Beginners should select patient with care, having good neck mobility without head tremors, with good cooperation and visible angle. Begin by tilting the microscope 30-40 degree towards the surgeon and rotate the patient's head 30-40 degree away from the surgeon. Patient should be in a reverse Trendelenburg position. This helps to prevent reflux of blood from Schlemm's canal. It is essential to have a good anesthesia. The patient should be relaxed as well as comfortable. Otherwise, it will be difficult for a novice MIGS surgeon to maintain visualization. In this video, we can see the difficulty in instrumentation due to inadequate anesthesia. There are a wide variety of lenses available. The handheld lenses include Swan-Jacob lens, iPrism SX, and Katina lens. A good high-density viscoelastic and a direct Goni lens are the essential weapons. Apply adequate viscoelastic before docking. Hold the lens in the non-dominant hand and gently dock to get a perfect in-face view. Now that we have got practice in intraoperative gonioscopy, let's take the baby steps into the world of MIGS. Bent ab internoneedle goniotomy. In this procedure, a 25-gauge needle is fashioned like a reverse cystotome. The bevel and the lumen form two cutting edges. The trabecular meshwork is excised. This is one of the most economical procedures with an easy learning curve. Studies have shown 15 to 20% IOP reduction with this simple procedure. Microhook ab interno trabeculotomy. In this procedure, a simple reusable microhook is utilized. The tip of the hook is inserted into the trabecular meshwork and the nasal TM is cleaved. The microhook is slender and easy to use for a novice surgeon. Literature has shown IOP lowering of up to 22%. Now, it is time to jump ahead to the next level, Cahook dual blade trabeculotomy. This is an excisional trabecular meshwork procedure using a specially designed Cahook dual blade. The tip is sharp to pierce the trabecular meshwork. The heel rests in the Schlemm's canal. The ramp stretches the TM and helps in complete excision. Here we can see the KDB blade excising the TM completely. Literature has shown promising outcomes. Gonioscopy-assisted transluminal trabeculotomy. A 5-0 proline suture is thermally blunted using a low-temperature cautery. The suture is placed in position through the side port. After getting a good in-face view, goniotomy is initiated in the anterior part of the trabecular meshwork using a 26-gauge needle. The blunted tip of the proline suture is introduced through the goniotomy incision. Gently, the suture is threaded 360 degree using max grip forceps. The blunted tip is grasped and the suture is externalized, completing 360 degree trabeculotomy. GATT has shown good IOP lowering in varying spectrum of glaucoma. Eye stent. The stent creates a bypass through trabecular meshwork into Schlemm's canal. It is injected and placed in position such that the body of stent resides in the canal. It is the smallest known medical implant. Long-term results are promising. India is advancing from low-cost lunar missions to bullet trains. We, as ophthalmologists, are also advancing with innovations in MIGS. We now have economic and easy MIGS options to tackle the burden. MIGS has added safer options in our fight against glaucoma.
Dr. Madhavi. So it was an educational video again. So anything that you think you've missed in this?
Sorry?
Anything that you think you have missed in this content that you have created for the budding glaucoma surgeons?
So basically the point was to start with the excisional procedures and then move on to the 360-degree procedures. Initially for a beginner it will be easy to just practice intraoperative gonioscopy first, then move on to the limited angle based procedures. Then maybe we can proceed to the 360-degree procedures. That was the whole point, but yes, I have not shown the difficulty. Some more difficulties will be there, but being the time
what is the
limit of
complication that you think is the
high
most?
FEMA.
So, and how do you prevent that? So I think without that, this video is incomplete unless you tell us how do you prevent high FEMA, because otherwise 100% will have high FEMA the next day. So I think that should have been covered. And any checkpoint that you can do after doing these surgeries that?
Yeah, leaving a viscoelastic at the end of the surgery has been shown to prevent the high FEMA on the post-operative day. We can titrate according to the blood reflex from the canal. Because of the time limit of the video, and I wanted to showcase all the videos. So
thank you.
Thank you.
Also, if you could have added on the learning curves, if some studies are there in literature which tell about what is the learning curve in adopting these procedures, if that could have been added.
Thank you, ma'am.
Can we have the next presenter, Dr. Obaidur Rahman, to present his video on basic nasolacrimal endoscopic evaluation with a handheld digital device. Co-authors are Dr. Elika and Dr. Seema Das.
This video demonstrates basic nasolacrimal endoscopic evaluation with a handheld digital device. The authors have no financial disclosures or conflicts of interest to report. Acryocysto-rhinostomy is a common oculoplastics procedure, with the external DCR approach being more commonly performed. This surgery creates a conduit into the nasal cavity. However, nasal examination is often overlooked. In India, only about 50% oculoplastic specialists perform pediatric probing under endoscopic guidance, while the rest still perform a blind procedure. The relevance of nasal endoscopy in DCR: it helps in delineation of nasal anatomy and identification of anatomical variants and pathologies. Postoperatively, can be used for assessment of ostium size and functioning, as well as complication assessment. Ophthalmologists face two major roadblocks in performing nasal endoscopy. The first one being lack of access to expensive instrumentation and lack of training, and the second one being lack of knowledge about nasal anatomy. To address these two roadblocks, the authors used a digital otoscope device. Originally, this device is an air wax removal otoscope, which was used for nasal endoscopy by the authors. It has a 4.5-inch LCD screen and a connectable camera probe. The camera probe has 6 LED lights for illumination, 1 megapixel camera with an excellent photo and video resolution, a working distance 20 millimeters, and can be easily charged with a mobile charger. The authors used this device for performing nasal endoscopy in external DCR patients. Here the middle turbinate is seen, and as we move along the floor of the nose, we can even see the nasopharynx behind. Preoperatively, the authors used this device for documentation of 6 landmark structures relevant to nasal anatomy in DCR, namely the lateral nasal wall, the nasal septum, inferior turbinate, middle turbinate, axilla of the middle turbinate, the maxillary line. Intraoperatively, this device was used for documenting the ostium. The ostium with the internal opening of the common canaliculus could be visualized. This device was also used for endoscopic probing in pediatric patients. Here, the metallic probe can be seen hitting the floor of the nasal cavity. Postoperatively, this device was used for ostium assessment Here, a dynamic 1-month costume can be seen. This is another 6-month costume with egress of clear fluid. In patients with silicone stents which were retracted after surgery, this device was used for visualizing these silicone stents and removing them under direct visualization. Here, syringing is performed after silicone stent removal. Post-operative complications could be documented, such as anterior nasal synecdoche formation, synechial closure of the ostium causing DCR failure, and granuloma formation around silicone tubes. This device could be used by DMB residents and fellows for performing independent nasal endoscopy after training. 13 trainees were trained using this device, out of which 46.2% had never observed nasal endoscopy before, and 84% could not identify more than one structure. After training with the device, 76% could identify all the structures correctly while performing endoscopy independently, while 84.6% believed that endoscopic teaching enhanced their understanding about lacrimal drainage and DCR ostium. When comparing this digital device with the conventional endoscopic system, it is easier to use. It has a smaller learning curve. It is portable, can be carried in the pocket of a shirt. It is battery operated and does not depend on external electricity sources. While the conventional system has a better image quality and a longer working distance. Talking about the cost effectiveness, this device is much cheaper when compared to a conventional endoscopic system with all its equipment. In conclusion, the digital otoscope device is a low-cost, handy utilitarian device which can be helpful in resource-limited settings and peripheral setups. It is easy to use and portable. It can be used for documentation and for teaching. The images and videos captured are easy to transfer and share. Thank you.
Dr. Rahman, so is it easily available, or have you been a part of this device development?
Okay, so I received this device as a gift from a prominent lacrimal surgeon who had acquired outside of India. But in India, you can easily acquire such devices on Amazon now, which can be connected directly to your phone also. And they are pretty cheap now. You can get them for around 2,000, 3,000. So even if you don't have the device, you just have that probe which I showed with the lead. It can now be directly attached to your phone camera and you can perform endoscopy anywhere.
So I think it's really interesting. The visuals that you showed from the nasal endoscopy, they were really interesting. Another thing that I would like you to add to your paper to give value to it would be the success of your DCRs without use of this and with the use of this, because you can see the ostium with the use of this and we're pretty sure. DCR, any other like?
Yeah, so if I tell you about probing, I've been using this device for around 1.5 years now. So I have seen a marked improvement in the success rate of probing. So in the past 1.5 years, I have had only 2 failed probings, which if I compare to before was much higher. That is one thing. The second thing is we had an ENT department in our hospital at one time. So there were some complicated cases or even after surgery that we had to refer to them. So after I started doing endoscopy on my own, there were 0 referrals to the ENT department because we could document and see what complications are there, and we could actually visualize why that complication is happening and how to correct it.
You also showed some complications. So what was the cause of those complications? Were they related to the surgery or related to the device?
So not related to the device exactly, but yeah, surgical complication and mostly related to inflammation or anatomical factors.
Okay, so is it because of the low illumination compared to the
So you cannot use this device for an endoscopic DCR surgery, but you can use it for minor procedures, basically OPD procedures and small procedures in the OT like silicone stent removal, pediatric probing. But a full surgery is still not feasible with this device. Yeah.
Okay. Thank you.
Thank you.
Can we have the next speaker, Dr. Shruti? Is she here? Okay, Chunat. Okay. Okay, Dr. Shruti, the title of a video is The New Phase to a New Face, Advent of Osteo-Integrated Implants in Oculoplasty. Co-author is Dr. Tarjani Dave.
Through a new phase of creating a new face. My topic of video presentation is on the advent of osseo-integrated implants in oculoplasty. This is a new addition to the armamentarium of orbital processes that we have. The conventional orbital processes are of two types, one spectacle mounted and two adhesive retention, but they have their own disadvantages. These pitfalls led to the idea of osseo-integration of orbital processes. Now, what is osseo-integration? Way back in 1960s, a Swedish physician and researcher, Professor Bainmark, discovered that when titanium rods are passed into a rabbit's tibia, it became one with the bone and inseparable once the healing occurred. This integration of bone with the titanium implant is called osseo-integration. The biological process behind osseo-integration is a combination of bone regeneration and remodeling, very similar to the healing process observed in fractures. Application of osseo-integration has further expanded outside the oral cavity to include the craniofacial area like BAHA or bone adhered hearing aid and implant retained ear processes. Here is a simple animated video showing the surgical procedure of osseo-integration. 3 to 4 titanium implants go into stable bone where osteotomy is already made. These implants have a magnetic property. The reverse pole of these implants is incorporated into the processes. So, the processes snugly clicks on and clicks off. The process of osseo-integration is a 3-step process. First, it's important to choose the correct size of implant which can sit into the orbital rim. The most commonly chosen are the supralateral and the lateral part of the orbital rim, as there is a good cortical thickness of bone here. A pre-operative CT orbit helps to determine the dimensions and decide on the position of implants. 2 adjacent implants should at least be 1 centimeter away from each other. With this assessment, a template is prepared before the surgery which can act as a guide in determining the skin marking and the exact points where the bone has to be drilled. Templates are of 2 types, 1 tissue supported and 2 bone supported. About 3 to 4 implants are placed on the lateral orbital rim to give a good magnetic grasp for the processes. The patient can be taken up under general anesthesia or local anesthesia if the patient is cooperative. Let us move on to the osseo-integrated step 1. With the help of a soft tissue template, the skin marking is made and joined together. Local anesthetic agent is infiltrated subcutaneously. Skin incision is made with a radiofrequency cautery. Progressively, the subcutaneous tissue, orbicularis oculi, and deeper tissues are incised with a radiofrequency cautery in order to reach the periosteum overlying the lateral orbital wall. Now, the periosteum is lifted away from the bone with the help of the sharp end of a periosteal elevator. Bone template is placed on the bone to help orient the direction of drilling. Pilot holes are drilled followed by sequential parallel twist drills in order to widen and deepen the osteotomy hole to the required size. Bone drilling is done perpendicular to the bone as it will affect the trajectory of the implant. Also, copious irrigation is given during drilling to avoid the dermal bone injury that can affect osseo-integration process. Now, the implant is inserted into the osteotomy after checking its depth and trajectory. Cover screws are inserted into the implant to avoid soft tissue entrapment and epithelial ingrowth. Periosteum is sutured together with absorbable sutures and the overlying skin is closed with 6-0 vicryl interrupted sutures. The instrument box used in this procedure of step 1 include surgical kit. On opening, it contains pilot drills and sequential drills for various dimensions of osteotomy like 3.4, 3.8, 4.3 and 4.8 millimeter. There is also a driver and a ratchet. By the end of step 1, the implant is placed inside the osteotomy and cover screws are placed on top of the implant to prevent epithelial ingrowth, and the skin is closed over it. After a wait of roughly 2 months for complete osseointegration, we take a CT scan again to confirm the position of implants with respect to the orbital rim. Now it's time to consider step 2. Let us move on to the procedure of step 2. The cover screws are palpated over the skin and the skin markings are made. Local anesthetic agent is infiltrated subcutaneously. With a number 15 blade, small skin incisions are made to expose the cover screws, and the cover screws are removed gently. Healing abutments are placed inside the implants now in order to form a fistula around the implant. So the basic concept behind step 2 is that the cover screw is removed from the implant and healing abutment is placed in order to form a fistula and is exposed to outside. Step 3 is the fabrication of ocular prostheses in the ocularis laboratory. This happens after 2 weeks of step 2. The healing abutments are removed and the implant keepers are inserted. These implant keepers have a magnetic property. The reverse pole of the implant keeper is another magnet which sits inside the orbital prosthesis. The impression from the patient is again taken to form a model. The process includes application of a light body material followed by random placement of sticks, application of heavy body material and placement of additional sticks. Over this, a layer of plaster of Paris is applied and left for an hour to set. Now, the model undergoes a series of processes like fabrication, wax trialing, iris centration, carving, texturing, silicone base color matching, extrinsic staining in order to mount into the final orbital prosthesis, which can be comfortably clicked onto the patient's facial defect. To summarize, the implant retained orbital prosthesis or osseo-integrated prosthesis are safe, durable and reliable. Despite its expanded use in oral, maxillofacial, ENT and orthopedic surgery, they are often an overlooked reconstructive option for the orbit. This can be an excellent orbital reconstructive option in carefully selected patients. The complication rate is low, the implants are well tolerated, and both the implants and prostheses require minimum long-term maintenance after the early post-operative period. This boosts the patient's self-confidence and increases the quality of life of our patients. As oculoplastic surgeons, it is imperative that we handle the disease and its iatrogenic repercussions. I thank you all for your patient listening.
Thank you, Dr. Shruti. I think that was an excellent presentation.
Thank you.
Is the device MRI compatible?
What is it?
Is it MRI compatible?
Yeah, we have done MRI also for the patients, but usually we go for CT because CT, we are doing basically bone drilling. So we need to see the cortical thickness of bone there.
I'm asking, after the device is implanted in the patient's eye, the prosthesis is there.
Yeah.
So if the patient needs to undergo an MRI, is it possible for him to undergo because there are magnets?
So till now we have not asked any patient to undergo an MRI because we have been following up with CT. But yeah, I understand.
The device is excellent. It's giving excellent prosthesis, and the abutment rate must be higher than the previous adhesive methods. But my concern is if the patient undergoes an accident and he's taken for an MRI, and then it becomes a difficulty. So it should be labeled on the device whether the patient can undergo MRI in future or not. So that is one important thing. Otherwise, the presentation was excellent.
In how many patients roughly till date you have done this, and what are
So
the complications you have seen?
Yeah, thank you for the question. So we have done this for 30 patients now, 30, and one patient had basically a wound woos actually because the place where we had kept the healing abutment had slightly, become loose. So he had a bit of a wound woos there, but then after, dressing it up and repairing it, the skin side of it, he was better. Other than that, all the other patients were tolerating it well because these were all basically post-excenteration muco patients. So their bone was good. It was not like irradiated orbit where the bone was bad.
Okay.
Other patients were tolerating well.
Okay. Thank you.
We can call the next speaker now, Dr. Shirley Gokharu. Yeah, she's the last one. She'll be talking about assess the outcome of adjustable suture levator resection technique in patients with ptosis.
This video demonstrates ptosis adjustable levator resection surgery. There are no financial disclosures and photo consents have been taken. Eyelid ptosis can either be congenital or acquired. Amongst the acquired types, eponeurotic ptosis is the commonest. Congenital ptosis generally leads to more predictable outcomes, whereas acquired ptosis carries a higher risk of both overcorrection and undercorrection. There is no established algorithm for determining the amount of levator resection needed in acquired ptosis, leading to frequent variability in outcomes. An adjustable levator resection offers a flexible solution to the same. This procedure was performed on a 30-year-old male with right-sided moderate ptosis and left-sided mild ptosis with both eye good levator action, secondary to chronic vernal keratoconjunctivitis. The adjustable suture technique via the anterior approach involved marking of lid crease in symmetry with contralateral eye. The surgery is performed under local anesthesia with minimal frontal block and some local infiltration. The upper lid is stabilized with a 4-0 silk traction suture and the globe is protected with a lubricated lid plate. Skin incision is made with a 15-number blade or a monopolar radiofrequency electrode depending on surgeon's choice. Layer by layer dissection of orbicularis is done. Dissection is proceeded inferiorly in suborbicularis plane till the anterior surface of tarsus is exposed. Similar dissection is carried out superiorly to expose the levator muscle with orbital septum. Once identified, the levator muscle is dissected from underlying molars and conjunctiva using the radiofrequency electrode and blunt dissection. Levator muscle is then tented with 3 4-0 silk traction sutures. Orbital septum is opened and the pre-eponeurotic fat is retracted for better visibility of the muscle. Interrupted sutures are passed using double-armed 6-0 proline through the central, medial and lateral tarsus and levator eponeurosis in a vertical mattress fashion. The sutures are left loose, untightened with long suture ends and secured with a bulldog clamp to prevent them from becoming entangled. The lid is initially positioned slightly ptotic with sutures tied into slip knots where the assistant holds the knot while tying to prevent slippage. This is secured with a sterile surgical tape or a micropore on the skin just below the eyebrow. Before applying the micropore tape, make sure the skin under the brow is thoroughly cleaned and dried to ensure better adhesion. Excess levator is resected and 3 skin sutures are carefully placed to form a lid crease. Care should be taken to avoid any overlap of skin sutures over the mattress sutures. The remaining skin is then closed with interrupted 6-0 proline and the eye is patched. Readjustment occurs 2 to 3 days later once the postoperative swelling subsides, making it easier to align the contour and height with the opposite eyelid. This procedure is performed in the outpatient department under topical anesthesia while the patient sits in a chair. After applying topical anesthetic drops and ensuring aseptic conditions, the slip knots are carefully opened one by one. The sutures are adjusted if necessary while monitoring the eyelid. The lid height is modified to match the palpebral fissure of the other eye, and the knots are tightened and buried in a small pocket between two adjacent skin sutures. The patient is then scheduled to return after 1 week for the removal of skin sutures. This procedure is suitable for both younger and older patients. It is best suited for those who are able to cooperate fully and manage the necessary adjustments without requiring additional anesthesia. This means the patient should be able to remain calm and follow instructions during the procedure. The procedure is appropriate for a range of challenging cases where outcomes may be uncertain, which includes eponeurotic ptosis, post-enucleation socket ptosis, traumatic ptosis, ptosis with blepharochalasis, ptosis secondary to ocular surface diseases, and ptosis after intraocular surgeries. The advantages of the procedure include being an outpatient procedure, it can be done under topical anesthesia, reducing the need for a second surgery. It eliminates the need for preoperative levator resection calculations, allowing for postoperative fine-tuning. It is an ideal for novice oculoplastic surgeons to practice levator resection techniques. And it avoids the discomfort of multiple in-theater adjustments, making it a versatile choice for various ptosis cases. Thank you for watching.
Thank you, Dr. Shirley. So it was very good presentation. Had you shown a video of removing the sutures and actually real time, so it would have been even more fun.
Yeah.
Thank you. Yeah.
Thank you so much.
So thank you, audience, and thank you, presenters, for excellent presentations. We really enjoyed watching all of them, and we are taking back so much home for us. It was a very, very knowledge enhancing and very nice session. The results we will compile, and you will get to know eventually. Thank you very much.
Thank you, everyone.
All the speakers on stage once for a group photograph, all the presenters, and even the co-authors if they're present and they want to come along.